always discuss on all the thromboembolic conditions, specifically the patients related with CAD, PAD, DVT, and pulmonary embolism. So low thrombosis has also received the award from Sims Medica Excellence, that is most engaging scientific platform for by any pharma company. So today's our host director is none other than Dr. Praveen Chandra sir. Sir is a chairman of Division of Interventional Cardiology in Medanta, the Medicity Hospital, Gurgaon. He is recognized as one of the leader in angioplasty in the country, and is proficient in a lot of new devices and technologies. He has been awarded for his contribution and services in the field of coronary angioplasty in India in 1998. Dr. Chandra has been distinguished faculty member in various international meetings and was the organizer and director of AMI course held in New Delhi for 2005 and 2006. He has published more than 100 articles, reviews, and abstracts in various national and international scientific journals. So next is our moderator is Dr. Vinayak Agarwal sir. Sir has completed MD and DM in cardiology and also fellowship in FACC and FAAC, FAHA also. Dr. Vinayak Agarwal sir is the head of Department of Non-Invasive and Clinical Cardiology at Fortis Memorial Research Institute. With more than 20 years of experience, his responsibilities including being in charge of the heart valve clinic and hepatic transplant cardiology division at the institute. Sir has spent a considerable amount of time on research, having conducted numerous clinical trials. So welcome, sir. Next, our moderator is Dr. Tapish Sahu, sir. Sir has, he is the senior consultant in division of peripheral vascular and endovascular science in Medanta, the Medicity Hospital, Gurgaon. And also, sir is working in, and also sir has published many articles and also involved in research and trials. And Manipal Hospital also, sir, as a senior consultant and looking at the division head in as a vascular surgeon in the Manipal Hospital also. So today's our both speakers, due to some unfortunate some emergency calls, Dr. Yanesh Shastri, Dr. Vijay Sharma sir is not coming. Today's the session is going to be one session going to be conducted by Dr. Ranjan Modi sir. He has completed MD DM in cardiology. He is associate consultant and interventional cardiologist from Indraprastha Hospital in New Delhi. Welcome, Ranjan Modi sir.
Thank you so much, Ravi. Good evening, Dr. Praveen, Dr. Vinayak, and Dr. Tapish Sahu. I think I'm the only whole and soul batsman available today, so everybody has to bear with me. Okay, so I think let's just start quickly so that we can end this now that if I'm only there. So I'm just, give me 1 second. I'll just try and share my slides. Okay. Yeah. Okay. I hope my slides are visible, Ravi, and I'm audible.
Yes, sir. Yes, sir. Yes, sir.
Good evening, everyone. Thank you so much for this No Thrombosis, another repeat platform for presentation. So let's talk about rivaroxaban and thrombosis. Let's look at all the clinical implications. What we're going to do in this is we're just not going to look at atrial fibrillation or DVT. We're going to look at all scenarios where we do require NOACs to be a part of it. And during this, we're just going to have an idea on how and why rivaroxaban might be one of the one-point treatment plan for most of these diseases which require anticoagulation. Dr. Ranjan Modi, I'm a consultant cardiologist in Indraprastha Apollo Hospital. Yeah, we all know there are significant benefits of NOACs OVK. There have been multiple lectures which have said that. Administrative costs are lesser, it improves quality of life, improved risk-benefit profile. They have a fixed dosing regime. There's no need for any coagulation monitoring. It's reduced potential for food and drug interaction is good. It has a predictable anticoagulation. I think most of the important part is that there's no routine coagulation monitoring required, particularly for an Indian setup, where patients become more adherent to the treatment. They are more compliant to the treatment. So that's how NOACs have helped us a lot. Now, there are various pharmacological characteristics which are present between the non-VK analogs, let's say rivaroxaban, apaxaban, and dabigatran. When we start looking at, we know they all target, apixaban, rivaroxaban target the factor 10A, where dabigatran is a thrombin. Oral bioavailability is a little high in rivaroxaban, almost about 80%. There's no prodrug, so it's easier. The Tmax is about 2 to 4 hours, which again is useful. So in 2016, the ESC guidelines for the same, they said that, atrial fibrillation, which is a major cause for stroke, if we calculate the Chadwick score and we look at stroke risk prediction, we will be able to find out if we do need anticoagulation or not. And they said that oral anticoagulations are initiated in the patients with atrial fibrillation who is eligible for NOAC. And the NOAC is recommended in preference to a vitamin K antagonist as a type 1 indications. And antipleural monotherapy obviously goes out of the picture completely as a class 3 indication, which is the harm indications. So NOAC dosing in patients with non-valvular AF, there are about few standard doses available, which are 20 milligrams of rivaroxaban, 5 of apixaban, 150 dabigatran, and the lower doses in cases of various renal failures, age, and weight being low, it comes to about 15 milligrams once a day, 2.5 twice a day, and 110 milligrams twice a day. So there's various criteria, as we said, about low dosing. In case of rivaroxaban, as we got the creatines go below 15, the low doses are recommended. In apixaban, we need at least 2 out of 3 these criteria, which is more than 80, body weight of less than 60, and serum creatinine more than 1.5. And dabigatran, there are multiple criteria for low doses, which is age more than 80, verapamil use, moderate renal impairment, gastritis, esophagitis, increased risk of breathing. Now, the question arises is, we've got 3 NOVACs available in India. We've got various conditions which do require NOVAC. Let's start looking at conditions like DVT, acute coronary syndrome, coronary artery disease post-MI, peripheral arterial disease, atrial fibrillation with a PCI stent, atrial fibrillation, renal impairment. Now, if we need to choose one, what would be the easiest NOVAC we could have? Now, when we start looking at this chart, and which are going to go criteria by criteria, as a whole, this chart will be easily available at the purple. The rivaroxaban is one of the drugs which is one of the most can commonly be used in all these cases of thrombosis and can be used as an anticoagulation. So when we look at DVT or acute coronary syndromes, apixaban is not indicated still in acute coronary syndromes, CAD post-MI or PADs, whereas rivaroxaban has been shown, 2.5 milligrams twice a day has been shown in various trials to be useful in case of acute coronary syndrome patients. So this is across the spectrum. Any disease which requires NOVACs, rivaroxaban can be used as a whole for all these patients. Now, even with patients with cancer-associated thrombosis, rivaroxaban has been shown to have a lower hazard ratio, which is about 64%. Major bleedings are also the hazard ratio is about 1.83. Apixaban, dabigatran, whereas do not have any safety data available with them. So when you look at rivaroxaban, is it a drug which can be used in everywhere? Now let's start deconstructing each category. Let's start looking at DVT. Now, if you have a 52-year-old patient and diagnosed with DVT, what would be a considerable treatment? Now, here the treatment change is quite dependent on the compliance of the patient. Are we looking for a single drug approach? So if you're looking for oral monotherapy, apixaban and rivaroxaban actually score over dabigatran, because dabigatran requires about 5 days of low molecular weight heparin, which can be followed by 150 BD. Whereas in rivaroxaban, we can start with a 15 milligrams BD for 21 days and then switch over to 20 milligrams once a day or 10 milligrams once a day. And apixaban the same, 10 BD for 7 days followed by 5 milligrams BD. So we do not need a low molecular weight heparin to be overtaken. So in rivaroxaban and apixaban, that's the best advantage we have. If you look at acute coronary syndrome, let's assume this patient has now been on rivaroxaban treatment and years have passed and now she's about 58 and now she's developed an acute coronary syndrome. Can we continue rivaroxaban? Yes, rivaroxaban and 2.5 milligrams twice a day with DAPT obviously is now been established protocol. So rivaroxaban can still be continued, whereas other NOVACs like dabigatran and apixaban have to be stopped and warfarin completely goes out of the picture. So rivaroxaban becomes easier for us if you're looking at various kind of scenarios, like we spoke about DVT and patient, and these are these patients who not only end up with us with one condition, they have DVT, then they'll end up with acute coronary syndrome, they'll get 2 stents, they'll then end up with an atrial fibrillation by an old age. So it becomes easier if we have 4 different diagnoses to be able to manage it with one drug itself. Now, rivaroxaban as secondary prevention of ACS, we know rivaroxaban 2.5 milligrams co-administered with aspirin alone or with aspirin plus clopidogrel or ticlopidine has been indicated for the prevention of atherothrombotic events in adult patients after ACS. And so we're talking about rivaroxaban plus aspirin plus minus clopidogrel. Now, this treatment is recommended for at least 24 months. And if the patient is after ACS continued to be at risk, then it can be extended as well. So now the patient had an MI. Now she's been event-free for the last 12 years. Now her age is going up. She has a chronic antithrombotic treatment is needed to prevent secondary prevention. Can we gain a peripheral arterial disease or a coronary artery disease post-MI? Yes, again, rivaroxaban here also helps us to be able to continue with a 2.5 milligrams BD with an aspirin of 75 or 200 milligrams. So it not only helps in a DVT, it helps in acute coronary syndrome, it helps in a secondary prevention as well, and also for peripheral arterial disease. So these are the most of the patients who end up, this is one of the most common journeys where we all see all these patients end up into. So when we look at dual pathway inhibitions with the rivaroxaban vascular dose of 2.5 milligrams BD plus aspirin, we see that the MACE reduced by about 26%. So if you look at this graph, we have on the blue line, we have the rivaroxaban 2.5 milligrams BD plus the aspirin 100 milligrams once a day versus the gray, which is 100 of aspirin once a day. We're able to see that the incidence, the risk factor actually of any major acute coronary event decreases by about significant amount with the combination of rivaroxaban and aspirin. Now, can rivaroxaban also be used? One of the most, as we grow older, one of the most common things we see in all these patients is atrial fibrillation. So can it be the one-stop solution? Yes, it can be. So now if you start looking at atrial fibrillation, we can use rivaroxaban also in the dose of 20 milligrams once a day or 15 milligrams once a day. Here is where most of these NOACs are able to get a chance to prove themselves, where dabigatran 110 or 150 milligrams BD and apaxaban of 5 milligrams or 2.5 milligrams BD are able to provide actually good anticoagulation for us. Also like rivaroxaban, they've not been able to be used in all of these other conditions like VT, ACS, CAD post-MI, peripheral arterial disease, but here atrial fibrillation, at least they're able to get used. So if we start looking at in all these 3 drugs, when we start looking at all these trials which were done, let's start and look who had the highest risk of stroke compared to in all these patients, in all these trials with all these patients. So when you look at Rocket AF with rivaroxaban, 87% patients had high risk of stroke. So the CHAT score was actually pretty high. Rely or dabigatran had about a 32%, where Aristotle had about a 30%. So the CHAT score was quite high, between 3 to 6 in 87% of the patients with the Rocket AF trial. And dabigatran and apaxaban evaluated across the spectrum of stroke risk, but rivaroxaban was basically, according to this, was evaluated the highest stroke risk group. We all know NOAC, perswarfarine, the trial summary. There have been various trials, and the Rely, Rocket AF, Aristotle, Engage AF, and all of these have shown that NOVACs have proven to be much more significantly better. If you look at the Rocket AF trial, rivaroxaban did prove its safety and efficacy. It did decrease 21% decrease in the stroke and the systemic embolism. The hemorrhagic strokes were brought down by about 41%. Non-CNS systemic embolism was almost down to 77%. Even in MI, there was a reduction in 19%, and overall CV mortality actually came down by 15%. And this, we are looking at about 2,500, almost 2,500 patients who had already an AF and a prior MI. So rivaroxaban just did not prevent stroke and systemic embolism. It was also helpful in preventing MIs and decreasing the chance of hemorrhagic stroke. Now, when we start looking at renal functions, The dose of where all of these drugs need to drop down for particular renal functions. There's no recommendation of NOACs in patients who are on hemodialysis or who have a creatinine clearance of less than 15 ml per minute. Dabigatran goes out of this picture when it's between 15 to 30 even. But when we start to gain 15 to 30, we do have rivaroxaban, apixaban, and edoxaban available in this in our arsenal. And as the creatinine clearance starts becoming normal, the doses keep going up. So we have apixaban of 5 milligrams or maybe 2.5 milligrams BD if the creatinine clearance is normal, but rivaroxaban dose goes up to almost 20 milligrams if it's between 50 to 95 ml per minute of creatinine clearance. Now, if we look at all these trials, one of the only drugs which were tested prospectively for specific renal dose was rivaroxaban 15 milligrams OD. We were able to show that rivaroxaban 15 milligrams OD is good from 15 to 50 ml per minute of estimated creatinine clearance. A lot of there've been a lot of talk about once we reduce these doses because of either of these factors of creatinine clearance in case of rivaroxaban or in case of age and weight, do they actually work? Does a reduced dose of NOAC treatment actually has an implication in a renally impaired patient, or are we just giving it to feel better? So when we look at these, at the hazard ratio in all of these patients who are on reduced renal dose at 1 year outcome, when we look at rivaroxaban versus warfarin or apixaban versus warfarin, apixaban actually increased the chances of stroke when a 2.5 milligrams BD was given. Whereas rivaroxaban, even at a 15 milligrams OD dose, was able to maintain and prevent ischemic strokes and also not cause any significant bleeding. So reducing of NOAC dose without an indication for dose reduction and against the label can actually increase stroke rates. We see a lot of prescriptions in which most of our fellows are not ready to write a apixaban dose of 2.5 milligrams BD, able to write a apixaban dose of 5 milligrams BD, and they end up writing 2.5. So it's important for them to understand that once you bring down the dose, the chances of stroke keep going up, specifically in cases of apixaban. So in summary, we've been able to, one, identify rivaroxaban as one of the drugs which can be given in creatinine clearance even up to 15 ml per minute. It can be given across the spectrum. It can be given from DVTs to pulmonary embolism to peripheral arterial diseases, in MI, in post-MI, as a secondary prevention for CAD and post-MI. In case of atrial fibrillation, yes, it's then been established. In patients with atrial fibrillation and PCI as well. The other NOACs like apixaban and dabigatran have no role to play in case of DVTs, pulmonary embolisms, and PADs. So we know rivaroxaban is the only anti-thrombotic treatment that can be tailored to improve health, prognosis, and survival. Rivaroxaban and apixaban are 10A inhibitors, whereas dabigatran is a direct thrombin inhibitor. Rivaroxaban and apixaban have low renal clearance. We can actually give it to up to even 15 ml per minute, whereas dabigatran, we cannot go below 30. Rivaroxaban and apixaban have a single dose of approach in DVT treatment. Dabigatran requires the bridging to a low molecular weight heparin. And because of that, there's always an increased pill burden in apixaban in the initial treatment phase of a VTE. The number of pills go up drastically because you're taking 10 milligrams twice a day, which is the number of pills goes up. Rivaroxaban is the only NOAC which has been approved in India for secondary prevention of ACS, chronic CAD, and chronic PAD. It's the only NOAC to be tested prospectively for specific renal doses. 15 milligrams OD has been now been said that it is important for a specific renal dose. Thank you so much.
Yeah. So I think, can you hear me, Vinayak?
Yes, sir.
Okay, lovely.
Good evening, sir.
Good evening. So I think, one thing I was realizing that, we have been reading and hearing about these NOACs for such a long time, and still we keep learning every time something or the other. That's very good. So wonderful talk by Dr. Rohit Modi. I think it was definitely useful. And of course, we have to, because this is the time when we have to make selections for our patients with multiple comorbidities. and renal failure is one of them, which is kind of outlined a little bit more today. And certainly looking at the GFR levels become very important. And typically, although there is so much discussion happening, and we actually started with dabigatran to start with, but now most of the people have moved on a little bit to apixaban and rivaroxaban. And certainly the unique use of rivaroxaban for chronic coronary syndrome is definitely there is no other medication for this kind of indication. So I think definitely rivaroxaban is a good drug which can be used in so many particular subset of patients, and single dose I think it works very well. So what's your thought about this?
So first, Dr. Ranjan, very nice talk. We kind of covered all the bases when it comes to NOACs. I think what I agree with Dr. Praveen Chandra, that these drugs have now been with us for about 12 years, 13 years. And they are now, we've used them in various indications. And somehow over a period of years, some of the molecules have become established and favorites of each individual, where probably the rationale may not be very strong, but you're just comfortable with that molecule for that particular indication. For example, if you talk about peripheral arterial disease or chronic coronary syndromes, I think rivaroxaban scores over others straight away. Even in ortho or spinal surgeries, I see a lot of rivaroxaban being used across board. When it comes to post-stenting, AF with stents being put or acute coronary syndrome, more I see is apixaban or rivaroxaban. Both are actually used simultaneously in most cases. Dabigatran used to be used earlier, but somehow I've seen the use of dabigatran decreasing over a period of time, apixaban taking over at many stages. Though for pure stroke risk reduction, we know that 150 BD dabigatran still holds true. For elderly, actually only, what we say is in the elderly age group, we prefer apixaban and dabigatran 110 because that has a little more, data. But I also agree with the slide which you showed that there is very little data with 2.5 mg BD in any of the trials. So 2.5 mg BD of apixaban is something which is a derivation or extrapolation of the data. There is no hardcore data that it really decreases the risk of stroke appreciably. So maybe we are balancing safety or hemorrhagic risk versus thrombotic risk in that milieu, and not with much of strong base at that point in time. So dabigatran can still come in handy because we do have data with in the elderly population. So I think rivaroxaban is definitely a very versatile molecule, can be used with 15 mg OD in renal impaired patients quite safely. 10 mg OD is being used by the peripheral vascular surgeons as well as orthopedicians quite often. So I think overall I agree with the flow of things that you showed.
Yes, I think so. If you look at the data, I think one of the most significant were apixaban 5 milligrams BD and dabigatran 150 BD. When we start looking at reduction of stroke, there was no doubt they were the most efficacious out of everything else. But the only concern becomes, as you said, apixaban. Most of, I'm sure a lot of us get prescriptions of apixaban 2.5 milligrams BD. I think as cardiologists, we're still very scared about bleeding. We're very scared about strokes. And I think that's one thing which always prevents us from giving actually the right dose in most of cases. And people do come with the 2.5 milligrams of apixaban BD. Most of the atrial fibrillation, as you said, patients are on apixaban. Most of the DVT patients are on rivaroxaban, most of them. But I feel rivaroxaban, actually, if you start looking at a spectrum of diseases where one patient may end up having a lot of them, like a chronic angina with an ACS, with atrial fibrillation and a PCI, rivaroxaban might be one drug which might be able to be help to take care of the entire spectrum of all these cardiovascular diseases.
Right.
I actually feel that, the COMPASS trial, which was basically post 1 year of ACS and chronic coronary syndrome trial in 2017, it was published. I feel that the dual pathway inhibition is very less utilized by cardiologists. I feel that that is a much better option in patients with polyvascular disease. And we are using that drug much less than what we should. So aspirin along with 2.5 mg BD rivaroxaban, I think is a very good option to prevent further thromboembolic or say CVD in future.
So Tapesh, I think,
Sir, good evening, sir.
And it's nice to see you after a long time. So please
Good
carry
evening,
on
sir.
and have good time and have some. Maybe I have to go now, and all the best.
Right, sir. Thank you so much, sir. Thank you so much, sir. So, Vinayak, sir? Yeah, so just going one step ahead of the literature, actually, this rivaroxaban has now become a household drug next to an over-the-counter drug for certain patients that they come up with the solution themselves that, sir, this is the drug we have searched on the net. So this is the power of marketing, and this is the power of that this drug, even I would say that the injectables have, because of the inconvenience, somehow this has overtaken and the injectables are also going down. So, but there are certain household modification, at-home modification, wherein they take 5 mg alternate day and say that we are on prophylaxis. They take 2.5 mg twice a week and they say that this is a drug that has been given by certain doctors there. So, having the bleeding risk in mind, certain practitioners are also doing their own modifications. So that's how things are, moving on. But well-read practitioners, and this no thrombosis program gives a literature-based, research-based outlook for setting things right, I would say.
I agree.
Thank you, sir. There is one question, two comments has come actually. One is Dr. Prabhakar want to ask that which NOAC do you prefer in NVF and DVT? And Dr. Rahul Kulkarni is asking rivaroxaban 2.5 mg BID can be used in NVF, as some study also published.
So I'll take up the second one first. Rivaroxaban 2.5 BD is only based on, along with aspirin 75, is based on the COMPASS trial, and it is only reserved for chronic coronary syndromes or stable angina or post 12 months of ACS or stenting, not for NVF at all. It is a subtherapeutic dose, and we should never use it. As for NOACs, I think this thing can be taken up by all three of us, or at least Dr. Ranjan can also comment on it, then I'll comment on it, the first one.
I think, sir, atrial fibrillation with the DVT, we know rivaroxaban is a proven drug with a 15 or 20 milligrams, depending on your. And why give two drugs if you can counter everything in one? Obviously, when you're giving rivaroxaban for DVT, then it takes care of atrial fibrillation as well. So all you need to do is just need to remember. And I think what rivaroxaban and apixaban do is they just help you to remember the drug doses very easily. It's 20 or 15. It's just becomes very simple. Creatinine between 15 to 50 is 15, and above 50 becomes 20. So all those things with dabigatran, which was 150 BD, 110 or 75, those things do not help you. So if you have one NOVAC which you can help for each other, I think rivaroxaban is the best for both of them.
Dr. Tapesh, any comments on what you prefer for DVT?
Sir, again, the same thing that you said, that therapeutic doses, not just the name of the drug, it is that you have to block the you have to block the coagulation pathway. So proper dosages, as Dr. Modi is also saying, that compliance and easy remembrance, easy prescriptions, easy availability, those are the things that patients do prefer. But as clinicians, we have to look at that only name of rivaroxaban, but 2.5 is not an anticoagulant. That's dual pathway inhibition, just blocking the platelets, not blocking the coagulation pathway. So in right dosages, this drug does give you a dependable response in clinical practice. And we have seen that over a period of time that, well, bleeding complications, certain patients do have come back with that, but more or less it's a safe drug to take in proper indicated patients.
I agree. So I would take, so if you look at non-valvular atrial fibrillation, there is, I think there is no one drug which fits all. I would say that in patients who have renal failure or renal dysfunction where the creatinine clearance is less than 45 ml per minute, I would not use dabigatran at all. In patients who are at very high stroke risk, I would prefer rivaroxaban over apixaban actually, because even in the ROCKET-AF trial, the average Charge-VAS score was around 3.5, much higher as compared to the other trials with, say, apixaban, which was somewhere around 2.1 or so. So I think we know that rivaroxaban is OD dosage, compliance is better. In patients who are in the elderly age group, I would prefer apixaban. Patients with GI bleeds, I would probably prefer apixaban, but probably equal. Dabigatran I would not use because it has a higher risk of bleed. Rivaroxaban has some plus minus issues with it, but then it's still usable. So I think in NVAF you choose wisely. You choose according to the patient profile. And rivaroxaban still is a very, very versatile and good drug in non-valvular AFs. It has a lot of data behind it, very safe in most conditions, easily titrable because you don't have to change the doses as much. The one thing which you have to remember is that you have to take it with food. That's very important whenever you're using 15 or 20 milligram of dose.
I think so. Apixaban, what it's called is post-COVID, everybody was on Apixaban. And I think that's where people's, there was obviously...
Depending on it more.
Yeah, depending on...
But then there was no indication, actually, there was no robust indication for using it. People were misusing it, if you ask me.
Yes, sir.
It was reserved only for severe COVID cases who were, in ICUs for prolonged stays. There you could use anticoagulation. And I think apixaban somehow, got used more.
And even in surgical cases, just because you do not need to be them to be on low molecular heparin, that's where rivaroxaban scores for, because most of the surgeons is just very easy.
Yeah, it is. OD dosage.
OD dose, and the chance of DVT goes off for any surgical patient.
Yeah.
So as we have been going through this no thrombosis for so many months and years now, but with the how things are moving in the past 5 years, I would say that rivaroxaban started on a very high note. Apixaban slowly picked up, but dabigatran slowly, despite it having a reversal agent, it's somehow losing pace. That I would say more or less in the clinical scenarios.
Yeah, which is also probably not right, because having said that, the having a reversal agent available is a great boon, in certain scenarios. In probably this year or next year, we will have the reversal agents for the FTN as well, and Dexanet next. So that would also come in. And either way, I think it's, I don't think that's the reason why we should be using a NOAC, because it has a reversal agent. That is just one of the reasons because of which we could use it. Like, for example, somebody who is prone to bleed, or somebody where we know the bleeding risk is high, maybe I would choose dabigatran over others because there is a reversal agent available. So as I said, that situation will demand what I choose. The clinical situation would probably demand what I choose. It's not like a blanket statement.
Exactly.
One more off the record thing, that some patients had a very funny logic that 150 mg is quite high and 5 mg or 20 mg is quite low.
Yeah.
They don't know the difference between the drugs. But somehow, the perception of people, what I'm talking about is 150 mg twice a day. Well, just name.
I completely agree. And, the problem is that a human tendency is to simplify or oversimplify everything. So simple concepts are absorbed better. So they form their own theories and facts which they create, and they think that is right. So I think it's our job also to educate them. And in fact, I feel that the pharma companies should also, spend time on patient pages, where you're doing, like, you have a lot of patient educational materials and patient pages, etc., being circulated in newspapers or magazines, etc., or in media. Now, of course, you have so much of electronic media. That will help, I think, in restoring the confidence.
Okay. Thank you, sir. Thank you so much. And it was really a very, very insightful presentation by Dr. Ranjan Modi, sir. And so once again, from behalf of Emcure, I want to say thanks to Dr. Praveen Chandra, sir, Vinayak, sir, and Tapish, sir. And also thank you, Ranjan, sir, for your presentation.
Thank
So
you.
with this, we'll close this program, sir. Good night, sir.
Thank you very much.
Thank you. Bye-bye.
Bye. Bye.